Good morning, everyone, and thanks for joining this session on syphilis, increasing prevalence in Victoria and its connection to AOD. Before I introduce our hosts, I wish to acknowledge I am hosting and recording this meeting from the lands of the Wurundjeri Woiwurrung people today. I acknowledge the traditional custodians and elders of the various lands on which you are living, learning and working on today, and any Aboriginal and Torres Strait Islander people who are participating in today's session. In the spirit of acknowledgement, I invite you to name the country on which you are joining us in the chat box today. So welcome, and I would like to introduce our two speakers today, Alvin Lee and Kristine Stone. Alvin has been a principal epidemiologist, bloodborne viruses and sexually transmissible infections, or the BBVSTI, at the Department of Health, Victoria, since November 2020, and leads the statewide BBVSTI surveillance program. Prior to joining the department, Alvin held a senior management role at the Sachs Institute, where he led the operational management and strategic development of the 45 and Up study, Australia's largest ongoing study on health and ageing. Alvin completed the New South Wales Public Health Training Program in 2018, where he worked across many areas, including epidemiology, research and evaluation, policy, risk assessment, communicable diseases, health promotion and partnership development. Some key projects that he led during the program included the evaluation of syphilis surveillance and public health management in metropolitan Sydney, and development of the New South Wales Public Health Response to Prolonged Smoke Events guideline. Kristine has been with the Department of Health for 12 years and is currently working as the manager of the Partner Notification and Support Unit. The PNSU is a small team of 5 that specialise in partner notification of STIs and managing HIV transmission risk behaviours throughout Victoria. Kristine is a nurse and has a background in psychology and recently completed her Masters in Public Health. So welcome both Alvin and Kristine, and I'll pass it over to you.
Right, thanks so much for that, Caitlin, and thank you to VADA for extending the invitation for Chris and myself to present this morning. So before we begin, I'd like to also acknowledge the traditional custodians of the various lands on which we're dialing in from today, and I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal colleagues that we might have in the virtual room. And for me today, I'm dialing in from the lands of Kulin Nation. So I'll be presenting the epidemiological summary on the increasing incidence of syphilis in Victoria, and my colleague Kristine Stone will go through its connection to AOD. So can everyone see the slides okay? Great.
Yep.
So a bit of notes on the data source, or where we're pulling the data from. As some of you might know, syphilis is a notifiable condition in Victoria as part of the Public Health and Wellbeing Act, which means that clinicians and labs are required to notify any diagnosis of syphilis or positive test results to the Department of Health. And the department also requests for the treating clinician to complete an enhanced surveillance data form that includes further demographic and risk information for surveillance purposes. And this is so we can better monitor the spread of syphilis and use data to help inform decision-making to help tackle syphilis in Victoria. So today I'll be presenting on data gathered from this state surveillance system. And there's a few key considerations that I'd like to highlight. And 2020, or data from 2020, is unique because 2020 was a strange year, and the true case numbers last year were likely to be underreported due to the COVID-19 pandemic. So it might look like there's a drop, but in reality, that's probably not the case. And data are subject to ongoing or are subject to change due to ongoing data cleaning and collection. So the data I present today might be a bit different, later down the track due to ongoing data cleaning and collection. So let's take a look at let's take a look at syphilis in Victoria over the past decade. So there's different stages of syphilis, which Chris will go into later. And I would just like to show you the data to paint the story. So as you can see, syphilis has been steadily rising the past decade, particularly infectious syphilis, which is the dark blue bars here. So annual infectious syphilis notifications are now about 5 times more than what they were 10 years ago. So in 2019, there were about 1,600 infectious syphilis cases notified to the department compared to about 300 in 2010. And what's particularly concerning is the re-emergence of congenital syphilis in 2017, represented by the orange little bars here. And as you might know, congenital syphilis is when an infected mother transmits syphilis to her unborn baby. And this can have severe consequences for unborn and newborn babies and is entirely preventable as well. And when we take a look at infectious syphilis notifications over the past 5 years by sex, we see that it's substantially higher in males. So the males are represented by the purple bar. And it's been increasing prior to 2020. And what's also worth noting as well, even though that males make up the majority of cases, the number of female cases has also been increasing each year. So it's about double in 2020 compared to what it was in 2016. So it's also a concerning trend. And when we take a look at infectious syphilis in males by sexual exposure, so who men are having sex with, we see that the majority of cases are men who have sex with men, which is highlighted by the yellow bars here. And opposite sex in both sexes, sexual exposure is a lot less compared to men who only exclusively have sex with men. And when we break down sex by age group, we see that the median age for syphilis in males is about 35 years. And for females, it's about 30 years. But when we take a look at the age groups overall, we see that the majority of female cases are of reproductive age, so from 15 to 49 years. And that's particularly concerning because of the risk of congenital syphilis if a woman is pregnant and has syphilis. And when we take a look at syphilis in Aboriginal and Torres Strait Islander peoples in Victoria, we see that females make up a greater proportion of cases compared to the overall distribution. And there's an increasing trend as well. So when we compare the trends of syphilis in Aboriginal and Torres Strait Islanders people versus the overall population, we can see that syphilis rates is substantially higher in Aboriginal males. That's represented by the blue bar here, or the light blue bar, and in Aboriginal females represented in the green bar, in the green line, sorry, compared to overall males, which is the purple line, and females overall, which is the red line. So I might take some time to explain this graph a bit more because we're using rates here per 100,000 population, and that's just a way that we can adjust so we have a common denominator when we compare how prevalent syphilis is across groups and with different population numbers. So in 2019, the rate of syphilis in Aboriginal males was about 125 per 100,000 population, which is more than double the overall male rate, which was about 50 per 100,000 population in 2019. And likewise, when we look at the rate of syphilis in Aboriginal females in 2019, it was about 65 per 100,000 population. And that was about 10 times the overall female rate, which was about 6 per 100,000 population. So I guess this slide illustrates the disparities as well between syphilis and how it affects the Aboriginal and Torres Strait Islander population more than the overall population. And it's also worth noting that syphilis is not just a local public health issue, but it's also a national one. So there's an ongoing syphilis outbreak across multiple jurisdictions in Northern Australia that's occurring in Aboriginal and Torres Strait Islander peoples. And it commenced in Queensland back in 2011 and has since moved on to Northern Territory in 2013, to Western Australia in 2014 and to South Australia in 2016. So I guess this slide highlights that it's not just a issue that's confined to Victoria, but also a national one too. So I'm going to hand over to my colleague Kristine soon, but before I did, I just wanted to summarize the epidemiological summary or the story that I guess we wanted to paint today, and that's that infectious syphilis has substantially increased in Victoria over the past decade, and men who have sex with men continue to make up the volume of cases. And the most concerning trends observed are increases in Aboriginal and Torres Strait Islander peoples, heterosexual men and women of childbearing age and those pregnant at time of diagnosis. And what's also concerning is the re-emergence of congenital syphilis from 2017 onwards. And the ongoing multi-jurisdictional syphilis outbreak is one of national priority at the moment to tackle. So that's it from me. Feel free to drop in any questions or comments in the chat, and I'm happy to get back to any questions while my colleague Chris presents. So over to you, Chris.
Thanks, Alvin. That was great. Good morning, everyone, and thanks for attending this session. My part of the presentation will look at just the basics of syphilis, the re-emergence of congenital syphilis, and then focus on challenges and opportunities in preventing new cases, outline the emerging complexities of AOD behaviours in syphilis, and also look at the public health response, including communication and workforce development activities. And I'll also provide some key links for you that you can look at later on. My first slide, please, Alvin. Alvin's my slide operator. So this is basically everything you need to know in one slide. I think you have to hit it a couple of times, Alvin. It's got it flows in. So syphilis is a bacterial sexually transmissible infection. It's passed on by direct contact during oral, vaginal or anal sex with a person who has syphilis. There are 4 stages of syphilis infection. Symptoms vary depending on the stage of infection. People with primary, secondary and early latent syphilis are infectious to their sexual partners. So primary syphilis can present as a chancre and it can appear at any body site and usually is described as a painless single ulcer. But it also may present as multiple painful shallow ulcers, and this is the tricky thing about syphilis and this disease. Secondary syphilis most commonly presents as a generalised non-pruritic rash, whereas during the latent stage of syphilis, there are no symptoms of syphilis, and it can only be detected by a blood test. Tertiary syphilis, while not infectious, can cause serious health problems, mainly in the brain and the heart. The diagnosis of syphilis is done mainly from a blood test, which measures antibodies, and it can take up to 3 months. So people that test may be negative early on. And syphilis can be transmitted from mother or pregnant person to baby, as Alvin's already stated. And during pregnancy, all women should be screened for syphilis. And it is treated with benzathine penicillin. So congenital syphilis. Untreated syphilis infection during pregnancy has serious consequences for the baby, including low birth weight, prematurity, congenital abnormalities, and even stillbirth. Complications can occur at birth, and they can also occur later in life. After more than 12 years of no cases of congenital syphilis, it re-emerged in Victoria in 2017. And unfortunately, we have had 10 cases since then. Sadly, 4 of these were stillbirths, and of the remaining 6 babies, 4 had syphilis complications at birth. When the re-emergence of congenital syphilis was announced with the first case in 2017, the reaction from the clinical community and the media was in agreement. How could this happen in this day and age in Australia? Indeed, congenital syphilis is 100% preventable. We have screening available, which is inexpensive, and it's offered to all women during pregnancy. Treatment is available and again inexpensive, and we still treat syphilis the same way we did 50 years ago with penicillin. So why is this happening? Next slide, please, Alvin. So each woman's story is unique, with her particular life circumstances, relationship with her partner, family, and also community environment, as well as access to care. This all contributes to her journey throughout pregnancy. Contributing risk factors in women diagnosed with infectious syphilis and giving birth to an infant with congenital syphilis include drug use, particularly methamphetamine use, homelessness and mental illness, family violence, gender roles, and also stigma associated with STIs are also other factors. Now, health services play a key role, and we have identified a number of challenges as syphilis has not been on the radar for quite some time. These challenges include just a general lack of awareness of the re-emergence of syphilis. I speak to many GPs all the time, and they're quite shocked. Oh, I didn't think syphilis was around anymore. And a lot of younger GPs haven't seen syphilis. Also, it's tricky because it's when to test, how to interpret results, and what the current treatments are, particularly in pregnancy, are not always known because we haven't been seeing it lately. Next slide, please, Alvin. So, why is there an issue with syphilis in the AOD space? Now, the information on this slide was obtained from the Hidden Harms document, and the reference link is provided. So dependency on methamphetamine poses serious public health concerns across multiple areas, such as BBV and STI transmission, heart-related issues, as well as psychiatric concerns. Risky sexual behaviour connected with methamphetamine use includes condomless or unprotected sex, higher incidence of anal sex, and more sexual partners. And this indicates that meth use is likely to contribute to a higher incidence of BBVs and STIs among both injecting and non-injecting drug-using populations. Safe sex messaging is tailored to different demographics: women, gay men, young people, and non-injecting drug users. And as I've just discussed, it has been shown that methamphetamine use can lead to a higher incidence of riskier sexual behaviour among all demographics. It makes sense then to tailor appropriate safe sex messaging to people who use methamphetamine in a way that is relatable to their experience. One size just does not fit all within the safe sex messaging. Resourcing needs to ensure that people, what is developed is relevant to the intended audience, and furthermore, know where to distribute this information. Next slide, please, Alvin. So some emerging research in the US looked at the relationship between syphilis and injecting drug use. And most notably, the CDC analysed national primary and secondary syphilis surveillance data in the US from 2013 to 17 and assessed the percentage of cases among women, men who have sex with women only, and men who have sex with men who reported drug-related risk behaviour during the past 12 months. Among women and men that have sex with women with primary and secondary syphilis, they reported the use of methamphetamine, injection drugs, and heroin that had more than doubled over this time. In 2017, over 16% of women with primary and secondary syphilis reported using methamphetamine, 10.5% had injected drugs, and nearly 6% had used heroin during the preceding 12 months. Similar trends were seen among men that have sex with women, but not among men that have sex with men. And these findings indicate that the substantial percentage of heterosexual syphilis transmission is occurring among people who use drugs, and particularly methamphetamine use. The article suggested that collaboration between STI control programs and also services that provide people that provide services for people with substance use disorders, it's essential that they address both these elements in those services. We don't routinely collect surveillance data on syphilis and drug use, but we are definitely observing more complex cases with drug use. Next slide, please, Alvin. So this is a story, a real story that I'd like to share with you. It's one of a young woman experiencing poverty and substance use, and while incarcerated, had a positive pregnancy test. She wasn't screened for syphilis though. After being released from prison, she didn't engage in any antenatal care, and she presented to hospital at the time of delivery. Luckily, she was screened for syphilis and treatment was initiated. However, she was then discharged with a referral to her GP to complete treatment. She needed 3 doses. She didn't follow up with the GP to complete her treatment. The baby was not treated, even though based on lab markers, treatment for both mum and baby were warranted. Her GP refused to treat her after that, and she was also diagnosed with gonorrhea, as was the baby. So after the case was referred to the Department of Health, our staff intervened. There were numerous conversations with the GP in the hospital, and finally, mum received her 2nd dose of penicillin at the hospital and then had her 3rd dose when she entered rehab. Her baby was treated and is fine, and luckily there's no signs of syphilis infection or abnormalities in the baby. But this is just, and this isn't just a one-off case. This is things that we're seeing more and more of now. Next slide, please, Alvin. This is another story, and it highlights our Syphilis in Pregnancy project. So we had a young woman experiencing substance use, mental health issues, and poverty and family violence. She did present for antenatal care and was diagnosed with syphilis late in pregnancy and didn't return for treatment and was lost to follow-up. The young woman was referred to the Department of Health partner notification officers and the Syphilis in Pregnancy project. And so my team run this project, and we worked closely with lots of different services, including AOD services, to support pregnant women diagnosed with syphilis who have complex issues. We support them to be treated, to be linked into antenatal care, and we take referrals directly from service providers such as yourself. So the Syphilis in Pregnancy project has an outreach capacity, so we can go out and we can find women, we can support them to come in and be treated, and we can also link them into services. So next slide, please, Alvin. I'm going to have to hurry quickly. So there's 3 pillars of the public health response that are really important. Prevention and education. Both men and women are at risk of syphilis, and we need to increase that awareness. Screening and treatment. We need to screen all pregnant women during pregnancy and anybody that's high risk later between 28 and 32 weeks. And partner notification. Syphilis infection does not give immunity. So what that means is that we need to also get women as well as their partners. And we can do that anonymously for people, and hopefully we can. And also, obviously, patient-centred care is also really important. Next slide, please, Alvin. Our response from the department. So we have an incident management team. We have an action plan. We're doing enhanced surveillance. We have the Syphilis in Pregnancy project. We only have a part-time worker, so our team has to absorb the rest of that. work. And also our Chief Health Officer has put out 4 alerts so far, informing healthcare professionals of what's going on with syphilis. Next slide, please, Alvin. The Victorian response. There's lots of messaging getting out there now, different communications, looking at different populations and risk groups, such as gay and bisexual men, people of reproductive age, Aboriginal communities, and we're also targeting geographical areas where we've seen clusters or higher incidence of syphilis, such as Mildura. We have an STI testing week. Last year, obviously, that was interrupted due to a lot of lockdown. It did happen in November, but it will be again reverted back to the 2nd week of September this year. So watch this space and encourage your clients to be involved in STI testing week. Next slide, please, Alvin. So some take-home messages. Test, test, test. When in doubt, we encourage everyone to be tested. That's the only way that you know that you've got syphilis and that it's also being effectively treated. Treat. When in doubt, we say treat. If people attend Melbourne Sexual Health Centre as a contact of syphilis, they're treated on the day that they attend. They're also tested and they don't wait for the results. And this is especially important if the person has challenges or a chaotic lifestyle, because they may not return. Educate. Sessions like these are really important for getting messages out into the community, and we try to champion change where possible. Next slide, please, Alvin. These are some really good links, some useful links for you if you'd like further training on syphilis, clinical public health management. There's a number of training options. They're online learning modules and webinars, and they're delivered by our workforce development sector partners such as Vital, Search, Family Planning Victoria and ASHM. And there's also the Melbourne Sexual Health Centre GP information line. I would probably give that out about 3 times a day to different GPs and people, especially when it comes to looking at results for syphilis, because that can be really, really tricky to understand those results. Next slide, please, Alvin. This is also some links for the epidemiological reports and also the online syphilis notification form. So if you need to notify syphilis, you can do it online. And my last slide. We are supported and really appreciate all the work that people are doing in relation to syphilis, including all the labs and clinicians who notify, our healthcare professionals who provide enhanced surveillance data, our teams that work so hard, the surveillance and epi team, the public health officers, and my team, the partner notification and support unit. And last but certainly not least, clinicians and healthcare staff who continue to tackle syphilis in the community. Thank you.
Thank you, Alvin and Kristine. That was a great presentation. Unfortunately, we've only got a minute left, but I'm sure if you do have questions for Alvin and Kristine, you can email us at VADA and we can pass them on. And I'm not sure, but are the slides going to be made available to us as well to pass on to people?
I'm happy for that, definitely. And
Right.
I'll also pop in a slide with my team's contact number, email address for anybody. If they would like to contact us to make a referral or get some support, we're more than happy to do that.